So now we have Dr. Kotelchuck, a professor of pediatrics at Harvard Medical School. He is also a senior scientist in maternal and child health at both the Center for Child and Adolescent Health Research and Policy at Mass General Hospital for Children and the Obstetrics and Gynecology Department at the Massachusetts General Hospital.
Well, thank you very much for the opportunity to speak. I want just to say, all the slides that I hand out, just think of it as I sent you a paper. I didn't really quite get what I was supposed to do, so what I'm going to do is I'm going to whip through my slides and mostly talk about the themes that I could hear everybody were really focusing on today and use the points I was going to make to talk to you about some of the themes you looked at. The most important slide turns out to be one that I use standardly in every talk that I give, which is a model of health policy development and how to improve children's health, mothers' and children's health. You watch at the end, you'll see it'll switch just slightly. That I did with Dr. Julie Richmond, who was a Surgeon General. And it says you need 3 different sectors to actually make a difference. You need a knowledge base, social strategy, and political will. Knowledge base is obvious, but it also includes the theoretical thinking of people like Neil, you just heard. Social strategies is how you move from one place to another. It covers a wide range of programs, and that's probably what many of the people who have been talking today have been telling you about various programs. And political will, it seems to be the dominant question of everybody in the room here, is where you're going to get the resources. Political will covers a lot of different themes. It is both money, it is legal possibilities, but it's also the willingness of all of us to engage in activities. Most of you have been talking today about getting money for major structural social determinant of health changes, social policy changes, but clinical practice policy is every bit as important to be thinking about as other sectors. And we may not have such great political will at the national level right at this moment, but we have political will in other places, and you've heard people talk about that. I wanted to do a couple things. I just had really 3 points originally when I first was invited. I wanted to tell you a little bit about the history. And the other thing I just want to say is I'm going to focus a lot on the prenatal part. We've heard a lot about child development, but your title is prenatal thing. And if you want to start, I do the first 1,000 days from conception. You could even go a little earlier than that if you wanted to be thoughtful. I want to give a little bit of the history of social determinants in the maternal and child health field. So it's broadly all of our fields. I want to introduce a conception that I have of how to think about the different interventions. I think we're not as precise in the way we talk about it, and I think that would actually help our work. I want to describe, I'll probably skip those two sector projects that are actually going on now. And I want to emphasize fathers. I want to spend a few minutes thinking about men and where they fit into our picture, and then make some end recommendations. So since I always have too many slides, I almost always start with my conclusions because it's really helpful. And if I get no farther than this slide, I will have given a good talk, or I hope it's a good talk. Anyway, so, I can see my own, it's a little easier for me to read my own things. Okay, the main points I want to make is that reproductive social determinants of health have been thought about for over 100 years. We are not the first group to be thinking about this topic, and I doubt we will be the last group to be thinking about this topic. And I just want to I'm going to highlight very quickly, I love history, but you may not want to hear the amount of details, but I just want to point out that 100 years ago, facing exactly the same set of issues we have right now, a proposal was made, a policy proposal called maternity insurance, that was universal health care and lost wage replacements. That was the proposal of the social determinant folks of 100 years ago. I would argue we're still fighting that battle today. That's Obamacare and paid leave. That was a great recommendation 100 years ago. We should be doing it now. The second point I want to make is that I think we're really imprecise in the way we think about what interventions we're actually doing. And actually listening today, I'm like coding people as you're talking to some of the other people, where you fit into this. It's a triangulation about 3 different sectors that I think are really important to think about that are discrete, separate sections in social determinants of health, namely issues around what healthcare professionals or any professional group that works in healthcare, not just docs. Social policy, and place-based interventions, which is what most people think of when they talk traditionally social determinants, and also personal agency interventions. I think these three different sectors are really critical. In the reproductive health world, they've really not thought much about personal agency interventions, and I think whereas some other fields have thought about that a little bit more. I have some recommendations within each of the three areas, but I just want to say that my main point I'm going to argue, and not very long today, is that poverty walks through the door of every clinician every day of the year. What can we do about poverty in pediatric and, more importantly, obstetric practice, where it walks through really early? And I think it's going to take a comprehensive approach. I know Jim works on practice transformation. I focus a little more on poverty issues within practice transformation, but I think we need a really formal set of activities, really think about it through. It took 20 years to get a medical home created in pediatrics. It's going to take 20 years for us to get this right about how to do pediatric care. We heard some fabulous examples today, but it takes a group thinking about it. In social policy, Massachusetts amazingly passed one of the most progressive paid leave bills. I'm like sitting on one of the natural experiments of life, and I think there's great roles for us, but there's some lessons there too. And then I do think we need to think a lot more about addressing parental agency, which I see as the kind of internalized personal consequences of poverty. It's a way of thinking about what is going on. There are other ways of thinking about it. There are two promising programs I was going to talk about, Best Baby Zone and also the Infant Mortality Social Determinant of Health, COIN, Collaborative and Improvement and Innovation Networks that I'm working with. These are just places where people are trying out new ideas, especially around reproductive infant mortality. Fathers are a key driver of social determinants for child and family health. And I have to say, the larger MCH professions, it's all of us, we do a really good job of not including them and not thinking about them. And the failure to think about fathers and their inclusion is to miss a critical issue in social determinants of health. And it's something we can do now. We don't have to wait for lots of other things. That's another thing. And then I would like to encourage the committee to be bold in their policy recommendations, which they'll never listen to me because there's no way you'll ever get this through. But really, in the end, those two ideas of universal health care and lost wage replacements really come down to Title 22 of the Social Security Act, which is essentially health security, and Title 23, which is the European ideas of child and family security. And we could think about that. At least it's a visionary idea of where to go. I know it'll never pass, but be that as it may. If you're interested in MCH history, there were really three eras in the reproductive where people have focused heavily on infant mortality and infant mortality reduction. And these are the names of them. The war on poverty was also an era, but in fact had very little to do with reproductive health as a driving force behind it. I won't bore you with all the key details, but the critical issue of infant and maternal mortality, especially infant mortality, it was the central public health issue of the 20th century. It helped define what public health is and also what clinical medicine is. And all of the ideas we have today kind of emerged in the American Association for the Study and Prevention of Infant Mortality. It was your single topic organization, whether it was environmental, nutrition, the emerging pediatrics, the emerging obstetrics field, and social work, who were the leaders of the Children's Bureau, which was first established. And I'm going to show you some of their data. The major historical fight I want to emphasize was whether the best to address infant mortality reduction through clinical health services, through these emerging fields, or whether to do it through social determinant health remediation. It's the same debate we're having to this day. This is the one great thing the Children's Bureau was able to do, since they couldn't run any programs, was they did studies. And this is a follow-back study done in 7 communities, medium-sized communities in the United States. Almost everything we know about infant mortality and reproductive health, I shouldn't everything, but a large numbers of the demographics came from this. This is the data that they found this is actually from 1915 to 1922. You see the wage gap, it's really very striking, okay? So what do you do about this? So one group of people proposed these two ideas. This is, I would say, the social determinant group proposed that there be universal government provision of medical care. I just want to emphasize, it was actually this is a social determinant, was the provision of care It has an access issue, and it was the direct provision, no pay. Okay. Paid maternity leave and nursing support, the lost wage replacement. These are the key idea that people were struggling with. Now, to be honest with you, the reason I mention this is it's important historically to understand how did the Europeans, how did the Europeans end up with a model that they did? They accepted this model for all intents and purposes. Here in the United States in the 1920s, when everybody was pushing this, it was like now, a very conservative time, the emergence of the capabilities of the two new professions, the American Medical Association particularly being really strong during this period. And these ideas came from the Russians and the Germans. We just lost a war and no one supported the Russians. They were defeated in every legislature that they were proposed in. And the net result is that we ended up with a very medically oriented set of issues around infant mortality in the United States. And I'll skip all the other details for a moment. The next era was the war on poverty. I'll just say quickly on this slide, the most important thing is reproductive health wasn't the critical issue, but major advances were made in social welfare. And the point I most want to make from this slide is it took a political movement. You're talking a lot about politics. The debate is going to be whether you need a bottoms-up kind of political movement or a top-down. That's actually one of the issues. We're a very parochial field. We don't tend to think a lot about political will. But this is one where there were major political movements and also great leaders who also supported some of these things. The second era was the era of comprehensive prenatal care. I and several other people around this table were very active in pushing prenatal care. The key thing of comprehensive prenatal care is if you're going to address social determinants in a medical-oriented system, the only way you can do it is adding it on to the existing healthcare system. That's how this topic first got broached in the United States. That's how I view this particular topic. We pushed prenatal care, we got access to it, comprehensive health education, social work. There was a discussion today about adding mental health to prenatal care. That's really of the same basic kind of model. We did a great job. I won't bore you with all how the politics of this whole thing worked, but the key thing was Medicaid expansion was the source of payment for this. And the delinkage of welfare from health care was the really key accomplishment of this particular period. The number of people covered by Medicaid jumped up to 40% of all births in the United States, which has really remained to this day. We've almost got universal health care. But prenatal care improved, low birth weight rates, nothing happened to disparities, and in fact, prematurity rates were rising during this period. So something wasn't quite right. But as I said, for the first time in 50 years, there was a rediscussion, a little bit of discussion about social determinants. Michael Liu, who's here, and Neil Halfin, who just spoke, introduced for the reproductive health world. This is their famous slide that essentially says you can't cure a lifetime of ills in 9 months of a pregnancy. And it puts arrows up and down. These are the social determinants we're discussing. This is a totally made-up chart, as Michael knows. He just graphed it out there. But it did capture the imagination of the way that we think about the world. It started earlier. Oh, no. Anyway, you've seen the chart. The third era is the current era we're in. That chart helped really galvanize this particular, for the reproductive health world. It brought reproductive health world into the world that was already maturing in the child development world that had moving on at the same time. The problem for everybody was, how do you actually implement this kind of a model? So I worked a lot at the federal government at the time, helping the Title V Bureau really think about using life course as a strategic framework. I'll just tell you a quick half a story. I would go out and share all these ideas. This is what life course is, and I talked to all the public health folks, and I'd say, so what are you going to do? You've now heard the truth. This is how the world works. And they still muddle, and I'd say, tell me how we're going to do this. And they would turn to me and they say, Milt, you're the expert. You tell us how to do this. So no one really knew quite how to do this. We've been struggling with how to think about it. Neil actually asked me to write something a while back in which I had to try to think about the research agenda. And I tried to think about the agenda for interventions around this. And I can't realize after thinking about all my entire career that really there were three basic sets of interventions that really captured almost all the groupings of interventions. If you don't think of it as a triangle, but as a three-dimensional thing, you can actually write a vector, which is what I do. I grade people. When you're making proposals, I say, how much of that proposal is going to be in the sort of healthcare side of the world? How much is really social determinants? So the example that was used about diapers and maternal depression, diapers is actually a social welfare policy issue. And it was linked in some ways to healthcare, but it wasn't a healthcare issue. And I think that we tend, and the new area for most people was just thinking about agency, sort of the impact that people have, the power that people have, and the pain that people have in sort of dealing with things. And many of our interventions actually are in that sector, but we're not very conscious of it. And I use this graph just to say, be precise. When you're talking about this, think hard. What sector are you working in? Paula Braverman and I worked on a project in doing teaching financial security to people in the Black Infant Health Project in California. She thought originally in the beginning of it that she was changing the social determinants of people. And I said, no, you're changing the agency of people. So you want to be able to think about this. You want to be able to see which sector you're actually working in and which ones you aren't. So moving on. And you can do, as you heard actually in the Cincinnati one, you could be trying to do some in all three sectors, but I think the precision you have in each sector is really what's kind of critical. I'm going to skip these slides, which you can all read at your leisure. I did want to say that most of you don't know that poverty is an ICD10 code. Do any of you use this, which would be a great thing to use if you're trying to get your institution to see the impact of poverty on all of its readmission rates, lengthier stay rates? We're killing ourselves. We need the finances of it, folks. And in the previous slide, the only other thing I wanted to just point out is, should poverty be seen as a chronic disease? If you think about poverty as a chronic disease, it changes the way you think about it. I have to say I get pushed back a lot on this one, but I think it's actually worth giving a moment's consideration because it's not a one-time event. Okay, I want to move on quickly to paid leave. We have a great paid leave program in Massachusetts, but the public health community did nothing to help get that bill passed, besides me speaking at the legislature one time. We have an opportunity right now to make paid leave, to use that to transform who gets care, who doesn't get care. Men as well as women are going to be eligible for this paid leave. The men don't even know about this yet. So are people going to take this? Can we use this? Can we use this to give, making people think about what a two-parent family caring for kids might look like or not? I'm going to skip these slides just as fast, if I can get these to move faster. I put a lot of slides in here. Okay. All right, fathers. I didn't want to, that's why give me 5 minutes. I was going to switch to this no matter what happened. Fathers are a social determinant of health. Let me just be really blunt about this. Their presence or absence is associated with family poverty. Father's income is associated with children's health. A father's presence and engagement is associated with enhanced child development. The child development world has been saying this for 40, 50 years. Father's presence and engagement is associated with healthier families, more stable health, and their relationships. Men are only tangentially conceptualized as social determinant of health factors, and then mostly negatively. Men, we don't want you in any of our services. You're going to abuse your partner. Like, we can't talk to your partner because you might abuse them. You're just kind of a pain. And fathers yet are really critical to child health and toxic stress prevention. I actually love the opportunity to read. I don't usually think about fathers in this, but I took Jack Shonko's earlier graph. I must have missed his newest writings. But fathers are essentially involved with all the adverse childhood experiences measures. They're critically associated with all three levels. Stable and responsive relationships. Most men's groups are teaching issues around relationships. My own Ph.D. thesis was on attachment of kids to their fathers. We showed that little kids, their development of love and attachment look exactly the same to men and to women. It's a really interesting thing. For men, the issue of whether or not they are generative, whether they think about love and other issues is very important. It's quite motivating to a lot of men. You can do a lot in this issue of having stable, responsive relationships. Safe, supportive environments, if they're not there, this is not going to be such a safe and supportive environment. They're useful in terms of, men can be useful. If you ask my wife, she'll say, I'm useful for a few things. So one of them is, I help make it a little more supportive. I loved appropriate nutrition. I'm doing a project called the First 1,000 Days in Chelsea and Revere in Massachusetts, in which I finally talked to people doing infant obesity prevention to include the dads. They were thrilled to be involved. Men buy food, cook food, set ideas about what's eaten and not eaten in family, model eating. They're very important in issues around appropriate nutrition. There's a lot of places, there are both cultural reasons why men don't participate, self-imposed cultural things, the view that women are the ones who take care of kids. Many men believe this. It's a self-imposed issue. But men are generally not welcome in health services. At Mass General, which is a typical hospital in the country, it's a very good hospital in the country, but there was no pictures of dads. There's no place for dads. I'm going to show you some data in one quick second. But the fact that men are not encouraged early to come in for that first visit, for the ultrasounds, which is when they do come in, and for delivery. So men are actually, as I'll show you, actually are showing up, whether people believe it or not. But if the current MCH services discourage men from being involved, it sends a message that the traditional views that only women care for young kids is the dominant culture. Our own group is actually perpetuating one of the more pernicious messages that is being sent out there. I looked with Michael Liu, among other people, to look at how fathers' health impacted on reproductive and child health outcomes. Once you start getting into it, it turns out there's a lot of different ways that men's own health makes a difference. We were doing this for men's preconception health, but really trying to think about the many different ways that does this, but including now optimal social determinants. But you can also ask the other question, what does having a child do to the father's health? How does he mature? Does he mature in that same way that women mature over time? What helps us allow the development of sort of generativity in men? And it's important, and it can be promoted and not promoted. Also, men are showing, as I'm going to tell you later, watching time, men show up for prenatal care. You can't get a guy to come to a healthcare visit, but they're all showing up for prenatal care, and they're sitting there waiting, and our data shows they're not so healthy while they're sitting and waiting, and they're desirous of things. Why are we not providing services for them? The obstetric community, of course, doesn't have a place for men in their scheme of things. It's not to criticize obstetrics, but just to say this is a critical issue. And I just came from a conference that demonstrated that men who were more happier fathers, more engaged fathers, actually turn out to be better workers and were more productive in many businesses and stayed longer at work than men who have a much more traditional role. We drew this graph to just remind you that even men's generativity is a life course thing, that there are many opportunities for boys to be trained to think about different roles of fatherhood than we actually do. Okay. And we did a survey that just, you can read it and then I'll stop in a second, and just say that we interviewed every guy who showed up for prenatal care at Mass General Hospital for 2 weeks in 1 year and 2 weeks the next year, including at the 2 neighborhood health centers that are associated with it. 400 guys answered our survey in 2 weeks and 500 the next time. 85% of them participated. And these were the main kind of findings. They loved being dads. They thought this was a great thing. That's not all that surprising. But 35% had no place to go to get any support for being a dad. Fatherhood had a tremendous amount of stress, and 26% of them signed off on one of the two items depression screener, agreed to having one of the symptoms. There were substantial problems in obesity, fertility, and lack of health services. The men all thought everybody treated them really well, but 40% said nobody asked them a single question during the entire time they were there for an obstetric visit. Men wanted more information, and they liked getting it by social media. And with this last time, we asked about kind of common MCH recommendations, and 35% of the guys were neutral or opposed to recommendations like breastfeeding, vaccination, and sort of safe sleep. Could have been I asked the question badly, but nonetheless, it was a high number. There's lots of things we're doing to include men, but we have a task force on fatherhood in MGH. There's a new fatherhood support group in the opioid treatment center, and we're working more to extend the fathers in nutrition kind of activity. As I said before, men come to health centers. Why are we not doing something about it? Okay, and these are my recommendations from early on, and same points that I made before. And again, I just repeat what I said right in the beginning. It takes a knowledge-based social strategy and political will to make a change. I gave you at least one new social strategy to think about, but I think political will is issue. And you might notice there's arrows between them. That's how we influence things. Sometimes when it's a bad period, you can still make a difference. So thank you very much.